addressing the pain, assessing to make sure that, that what we're providing is working and that there aren't discomforting side effects or adverse effects that would make people stop taking pain medication or stop doing the treatment that you're providing. So we have to keep asking that. Is their functional status better? Are they sleeping through the night? That would be, in my book, would be a major victory for many people. And then lots of education. And it's not just pain medicine that we give. It's also, can we treat your anxiety? Can we treat your depression? Can we prescribe exercise or stretching or hot or cold or biofreeze, or there's all kinds of things out there that, that can help with pain. So it's not just medications and it's not just one size fits all. I'm just going to go to key terms. And the big one is physical dependence. So if you are taking opioids for any length of time, you will be physically dependent. So if you suddenly take the opioids away, you will go through some level of withdrawal symptoms. So you won't feel well, you may feel like you have the flu, all the way up to having seizures, depending on your situation. So physical dependence is not the same as addiction, and that's a real common misperception out in the public. Tolerance is another word that we sometimes use, and that's just that you might need more pain medication over time to get the same amount of pain relief. And sometimes you need more pain relief or more medication for pain relief because your disease is progressing, but sometimes it's just because of that phenomenon of tolerance. There's pseudo-tolerance, and that's where we're, like I said, increasing because the disease is progressing, and so you're having more pain. Addiction is where you're using a medication basically not for what it's meant for, which is physical pain relief. So it's compulsive use, impaired control over drug use, the phenomena of craving and continued use despite harm. And I'll talk about that in just a minute. And then pseudo-addiction is where we sometimes as providers or people that are trying to manage pain, we're looking at somebody and thinking you're looking at drug-seeking behavior, but what we're looking at is maybe we are not managing their pain as effectively as we can. So they're doing everything they can to get more pain medication. It could be addiction, but it can also be a case where if we really listen to what they had to say and maybe change some things with them and their pain was relieved, the behavior would go away. There's just a couple of more terms, and one is substance abuse, and that's where you're actively using prescription drugs for reasons other than indicated use. And I kind of say, if you're taking it for physical pain as prescribed, that's okay. If you're taking it to make your spouse look better or enjoy living with them, that's really not what that medication is meant for. So that might be substance abuse. So it could be alcohol use above what's considered reasonable. It could be use of illicit substances for effect, or it could be use of legal substances, but more for effect than for physical pain. And then misuse is a little bit different. It's where you're using it other than it was directed. So that can be willfully or not. Some people, think, well, if 2 is good, 6 is better. And so sometimes there's a lot of education in there. Sometimes it's willful. And then diversions, that's where somebody's actually removing medication from legitimate distribution and dispensing channels. So that's sharing, that's stealing, that's going through people's medicine cabinets and taking one of each. That's more diversion. We do find sometimes out in the community, people are taking medications meant for grandma, opioids, and they're selling them. And sometimes that's paying for the groceries. Sometimes it's paying for a trip to the Bahamas, but sometimes it's actually a need, an income need, which isn't really what that's meant for. So that would be an example of diversion. So I know I'm talking fast here. So I usually use this as just an example, and hopefully it'll help people understand. And I know some of you have heard this before, so please bear with us. But I usually talk about the shoes. So we all wear shoes. We live in Alaska. Anybody here not wearing shoes? Everybody's got some shoes on. Chances are, if I looked at your feet, you're wearing shoes that are appropriate for our climate and for the time of year. You're probably not wearing 2 pairs of shoes. You probably don't have, you may have an extra pair of shoes stashed somewhere, but you have a plan for that. So if you think about it, the shoes allow us to do a lot of things that we couldn't do when we weren't wearing shoes. And we actually are physically dependent on our shoes. So if I took everybody's shoes away today and made you walk home, you would actually be going through what I guess I would call shoe withdrawal because your feet are not up for it. Your feet are not tough enough to make that all happen. So you can think of that in a way as a physical dependence and then withdrawal. And most of us enjoy buying new shoes. We may have a lot of shoes, but if you think about addiction is where I have a false back on my closet, so my husband doesn't know how many shoes I have. Or I'm picking up strange people in the mall and whining and trying to get them to buy me shoes. Or I'm lying about my shoe use. Okay, so that's addiction. So I have enough shoes. I have what I need. If I take my shoes off and I try to walk home without my shoes on, I'm going to go through a shoe withdrawal, and I'm going to go home and put some shoes on. You can guarantee that. But in general, most of us don't have a shoe addiction. So does that make sense? So the physical dependence, the addiction, and just the fact that people, no matter if you have the disease of addiction, that doesn't mean that we can't effectively manage your pain. We might have to make some agreements between us. We might have to take some different approaches to make sure that you're safe, but we can still manage your pain effectively. So that's my 20 cents. Thanks.
Thank you. Okay. Appreciate that. I'm going to move next to Dr. Ursula McVeigh and ask her to come up. And Dr. McVeigh, do you want the lapel mic or do you want the handheld mic?
I'll take the handheld.
Okay, perfect. I will give it to you in just a minute. I just wanted to say that Dr. McVeigh is the medical director of palliative care here at Providence, Alaska Medical Center. And prior to coming to Alaska, she worked in both Vermont and in Boston, right?
Oh yeah, just 1 year.
Okay.
Vermont for 15.
Mostly Vermont. Okay. She is board certified in both internal medicine and hospice and palliative care medicine. Graduate of medical school from Yale. And we'll skip the Boston. Mostly, we're just excited to have her here in Alaska and to hear from her about the things that are going on in her world. So, back in the fan, hand it to you. Do I need to get this up right here? Just a second.
Can you hear me? All right. So I'll be talking about palliative care, pain management, and the impact of the opioid epidemic on access to opiates for patients with cancer.
Oh.
Should I just say
Pat.
okay?
Yep. There we go.
And then for moving forward, you can use these.
Okay.
Okay, I don't have one of these.
No problem. I'll
So we have
stand
one of
here.
these. Okay.
So I'll talk a bit about the role of palliative care in cancer care, discuss the impact of the opiate epidemic on cancer care, and then I'll talk a bit about how opiates can be safe and effective for patients facing uncontrolled symptoms of cancer and advanced disease. And this is a guy coming to the doctor. He has a shark on his arm. A lot of medicine is about like what's going on, and he has pain, but he thinks it's probably the shark. And we should probably take the shark off your arm, but some people live with it on their arm, and that's what cancer pain management is really about. is helping people live well while they still have something that is uncomfortable and unwanted in their body. Palliative care is specialized medical care. It focuses on providing the relief of symptoms and stress of a serious illness. The goal of palliative care is to improve quality of life. So if we look at the last slide and think of that shark, a lot of medical care being disease-directed is trying to treat the disease. Palliative interventions look at relieving the suffering from the disease. So if someone were pursuing cancer-directed treatments and their cancer could have a chance of being cured, that would be curative intent cancer treatment, but they might also be getting pain management or nausea management, and that would be considered palliative treatments for the symptoms of their disease. So palliate means to lessen or soothe. The field of palliative medicine, where people specialize in this field now, the field of palliative medicine focuses on people with serious illness or cancer at any stage, and we look at using a biopsychosocial spiritual model to alleviate distress. Bio being the physical, there's physicians and nurse practitioners on the team that focus on symptom management. Psychosocial, spiritual are the emotional, psychological, and concrete social needs, and spiritual existential things that happen when you face something that changes your life. And we look at this team to alleviate distress from all of those directions. Being the physician on the team, a big role of what I do is cancer pain management, and that's probably 80% of our referrals to our outpatient clinic. But I will go back to say that palliative care, primary-based palliative care, is really any specialist working with a serious illness who's trying to alleviate suffering and improve quality of life. And for cancer care, a lot of palliative care is started in the cancer clinic or by primary care, or people might see a pain specialist. And so all of these interventions are palliative, but then every once in a while there's something that is difficult and needs extra attention, and that's where a specialist might get involved, just to explain kind of the broad range of palliative care and then the role of the specialty. Oh, yeah, I appreciate that. Sorry. It's just happening. So opiate use for cancer-related pain. This is Cochrane reviews, or this evidence-based medicine structured review of all of the research that's ever been published. And then this is a review of all of the reviews that were done on opiates. And what they found is, for people with cancer, about 1 out of 2 or 1 out of 3, so a third to a half of patients with cancer will at some point suffer from pain that's either moderate to severe in intensity. Not everyone with cancer has pain. But a substantial amount will have moderate to severe pain at some point in their course. Morphine has been taken by mouth. So morphine has been a medication, been used for pain and for cancer-related pain since the 1950s. In 1986, the World Health Organization came out with what's called a pain ladder to instruct people on when to use opiates and what strength of opiates based on how bad their pain is. And recommended stronger opiates like morphine drugs for moderate to severe pain for people with cancer. So since the 80s, it's been a recommendation from the World Health Organization to use opiates for moderate to severe cancer-related pain. And there's a number of different drugs that fall under this range of opiate drugs. It's morphine, most commonly oxycodone, hydrocodone, fentanyl patch. All of these drugs fall under the name of opiate. Sometimes we use the term narcotic, but that's not really appropriate to discuss these medications when they're used under prescriptions from providers, because narcotics are illegal substances and also include heroin and cocaine. And so these are opiate medications that have strong evidence and indications for use in cancer pain. So in this review, when they looked at the effects of using opiates for cancer-related pain, they found that 19 out of 20 people on average, and this is a sum of all of the research that they kind of pulled through, 19 out of 20 people will have relief using opiates for their cancer-related pain, and usually within 14 days. I just say that to say it is, for cancer-related pain, it can be a very effective way to alleviate pain, and it can work fairly effectively within 14 days. But most people will have side effects that will be managed, and the most common is constipation. It is so common that I tell people up front about it to treat it. And anyone who's taking an opiate on a regular basis, in my training, should also be given a stool softener, because I haven't met anyone that takes more than 1 or 2 opiates a day. Very rarely that won't need a stool softener in addition. About 1 in 2 people out of 10 in these studies would have to stop or change their treatment because of side effects. And nausea is another side effect from opiate. So we see that opiates are the standard of care for many forms of cancer-related pain. They're effective and they're safe for cancer pain. And then there's barriers that exist to access to these opiates. But then we have the other side of this coin around opiates and access and psychology around opiates because of what is now being called the opiate epidemic. But think about what if we actually called that what it is, which is an addiction epidemic, what that would mean about how we actually addressed that. But calling it an opiate epidemic and looking at the problem as being opiates and overuse, access to opiates, the predispositions and the determinants of substance abuse that we're just maybe starting to look more seriously into understanding. And then thinking that curbing opiates is the answer to the opiate epidemic. The use of opiates for pain syndromes that respond poorly to opiates, and we also, while we curb the opiate epidemic, we also need to make sure we're taking good steps to make sure there's good access for opiates for patients with cancer. Anything we haven't kind of talked about? There'll be more time at the table discussions, but.
Well, there's also the barrier of the pharmacy may not have the quantity to dispense your prescription. So you need to go to multiple pharmacies to find. So sometimes a pharmacy may not have stock on hand. So there's questions for some of the medication depending on where you live, and access in rural communities or our bush communities is even more difficult. So access continues to be, just having the full dose to fill the script is an absolute concern week in, week out.
And what happens if a pharmacy says, I don't feel safe because we might be targeted to have opiates stolen because of addiction disorder, but what are we doing then to have access to opiates for people that need it for their cancer pain? Or end of life, and that's a whole other thing. We'll stay for the Cancer Policy Forum on that, issue. So the barriers to the access and then the patients and the families and their perceptions and what that feels like to them when they're taking these drugs or maybe won't take them because of that stigma. So actually I'll just highlight that there is an opiate risk tool. There's evidence around the risks of developing a substance abuse disorder in using opiates that's taught to be used by providers to help assess when you're working with someone in prescribing opiates. It's not to say that we're not careful about making sure people don't develop addictive disorders related to our cancer pain management. And sometimes patients have active substance abuse disorders and have cancer pain and need opiates. And so it takes a lot of attention and an inter or multidisciplinary team to help people. But there's ways of identifying patients at risk. There are steps to help minimize the risk of that opiate getting out of control. And there are ways to use opiates and get people access to substance abuse programs. I'm not going to go through this except to say the National Comprehensive Cancer Center has a great guideline on how to titrate opiates. And if you're a primary care provider and you have someone with cancer and you're thinking they have uncontrolled cancer pain and I don't know what else to do next, of course there is curbside calls and there's referring your patients, but there also is support in how to change the dose and go up in increments so that you're safe. One thing has become of this opiate epidemic is sometimes providers are uncertain what an overdose even is, that they're not willing to even go up 50% on an opiate for someone with uncontrolled pain, which would be a very safe increment to increase. And so all providers need to know how to prescribe opiates safely and how to adjust them and to understand at what point puts someone at risk for an overdose. Tripling a dose would be an unusual and unnecessary step in someone with uncontrolled pain and could put somebody at risk of being sedated or even in an overdose state. I would never have someone who took one Percocet who says I'm not comfortable say, well, next time take 3. And this gives some guidance around that. Increments of a half to doubling a dose in a dose that was previously tolerated is not going to cause an overdose. But providers need to feel responsible that they have to know. They can't just say, I'm worried that you might overdose. They should have access to information if they don't already know or call curbside or refer to make sure that their patients can have their doses adjusted if they have uncontrolled pain. So my summary is opiates are important for cancer-related pain, and addictive disorder is rare, but it's important to watch for as well. And provider familiarity with dosing guidelines is an absolute requirement for us to take good care of our patients. Thank you.
Thank you. I'm going to ask thank you, Dr. McVeigh, Dr. Tom Grissom, to join us up here. The most important thing about Dr. Grissom's background, of course, is that he's a Husky. Kinda.
Went to med school.
Went to med school at University of Washington and has been in the field of pain management for pushing 20 years now. And a couple other things I just wanted to highlight. A member of the American Academy of Pain Medicine and the American Society of Anesthesiology, certified in anesthesiology and pain management by the American Board of Anesthesiology. And I'm going to say without further ado, turn it over to you, but give me just a second.
There's also another problem in the opiate epidemic. And so right now, we've had some steps taken recently to look at curbing the non-beneficial use of opiates in our society so there isn't as much opiates going around, and to not have opiates overused for conditions that don't need opiates that might predispose somebody who, someone who might have even predispositions, could develop a substance abuse problem by having access to opiates, and maybe they don't need opiates. So there's these two sides to the coin. And I do want to say one side of this coin, the opiate epidemic, is a really, really important side to this coin. And there's a lot of education and talk about this. And in that slide, which way am I going? Go ahead. Up to. Yeah. So when they look at overdose deaths from opiates in the United States, you can see since 2000, any opiate, it's just been escalating really rapidly. It's a very serious problem. Heroin is still the #1 opiate agent of any single agent that is implicated in an opiate overdose death. But if you took all the other opiates on this screen are prescribed by providers, the sum of all of the opiate overdose are actually started with a prescription. That someone was prescribed an opiate in some way. That opiate was then through diversion or stealing or a person getting an opiate but using it outside of its instructed indications, using it at doses higher than what's prescribed, or where people are at risk for having an overdose of an opiate. So that's real evidence to have us look at what are we doing with our opiate prescriptions in this country. And that's the foundation for a lot of the CDC guidelines around how to, at least our first step in addressing the epidemic. So this, in 2016, the CDC issued this guideline for prescribing opiates, looking at chronic pain. So it was, their aim was to improve our prescribing of opiates, to expand treatment of addiction, and to reduce access to illegal opiates. So this triple aim of their guidelines. And they also wanted to expand access to the use of naloxone, which is a reversal agent. So if someone was witnessed at home to have an overdose from an opiate, a bystander could administer naloxone and reverse it immediately and save a life. Third, they want to promote the use of a state prescription drug monitoring program so that providers know if a patient is getting drugs from other providers as a red flag for not using drugs as prescribed. And so those three things are kind of unfolding. This guideline is not meant for us to review, except that I want to highlight this little red circle. So they came up with this checklist. There's a 30-page document that instructs providers about how to curb the use of opiates for potentially non-helpful pain syndromes that don't respond to opiates. So it's looking at chronic pain management and trying to use non-opiates when effective and when able, And it's in this guideline, there's this little thing in the corner that says, this is for primary care providers treating adults with chronic pain greater than 3 months, but it excludes patients with cancer, palliative care, and end-of-life care. That exclusion has sort of missed our radar when we've looked at kind of the policies that are coming out around opiate restrictions, because we have to remember that this curbing of the use of opiates for syndromes that may not be responding well to opiates, or that might be giving people medications they don't need that they might divert, that scrutiny on doing curbing that use is really impeding our ability to get opiates to people with cancer-related pain who are using it safely under the direction of a provider and are benefiting for the ways it helps them do the things they want to do when their pain is relieved. So that little asterisk in the corner of the guidelines, when you dive in and say, well, why is there an exclusion for people with cancer or receiving palliative treatments? And that in that instance, they're using the term palliative care for a progressive life-limiting illness that has uncontrolled symptoms. So the patients within the scope of this guideline, though, are, as Pat mentioned, cancer survivors might have chronic pain. They might have completed their cancer treatments, and they might have a long life ahead, where opiates might work well for short-term pain management, but they might not be a good 20-year solution to manage the pain that they're facing. They also exclude, they do include, the guidelines are meant to be for patients with cancer in remission. So it's not just meant that patients with cancer, we don't have to be careful about how they're using opiates. It's really meant to say if this is cancer-related pain, the evidence is so strong and the expert recommendations are so solid that opiates are indicated, are safe, and they are used safely under direction of providers. But it is intended, it's not intended for patients undergoing active cancer treatment or patients receiving palliative or end-of-life care. So why the exclusion? This was one quote in the document. Because the unique therapeutic goals, ethical considerations, opportunities for medical supervision, and balance of risk and benefits with opiate therapies and such care is different. I gave a piece of some of this presentation with oncologists, and one of the oncologists said, we see our patients sometimes every week when they're getting cancer treatments. And we're working with people that do not want to even feel the slight bit of grogginess. We are dosing these drugs in ways that, for people who are trying to maintain their lives, they're not going into the escalating of doses in the range where you're looking to escape life or treat psychological distress, as Pat mentioned, to have your husband look better. They're trying, people don't want to be groggy. If they feel the slightest bit of grogginess or feeling altered, like not like themselves, they don't want to take the drug again. They're really fighting to live their lives, and we're dosing opiates in such a way that we're not having them be at risk for being altered, and we're really nowhere near the doses, which are not the medically prescribed doses that cause overdose and death. An opiate overdose is someone who is unconscious and cannot be aroused, and their breathing is slowed and then it stops. And we're dosing opiates and really looking finely at, are you getting a little groggy? Well, let's just hold there or cut back. So we're nowhere near in a range of where someone would be at risk for an opiate overdose. I know that's actually an open slide for a discussion, but thank you. This is a bit of I was going to come up and say, well, what have we seen? And since the CDC guidelines have come out, and as we've been having so many more discussions about the risks of opiates in our society, what have you seen for people with cancer and the impact this has on their access to safe, effective, and timely opiate use? Have you seen?
Many of my patients are terrified to take opioids now because they're watching the news and they see this all the time, and then they suddenly feel like they're becoming this person that's abusing opioids. And so there's not a distinction made on social media about cancer patients as an exception. So the exclusion that you mentioned in the CDC guidelines is not included on any social media, and it's really a barrier for many of my patients to begin to get adequate pain management. In fact, their lives are so negatively impacted by pain that they're doing much and much less than they normally would. So functionally, they're declining, and they're more resistant to taking opioids to this war on opioids.
And say, how often do you feel like you're trying to help someone consider opiates?
Wow.
As opposed to them?
Right. Yeah, they're not coming to,
They're not
coming
coming
to me. I'm
to
looking
you.
at them and the family is just, in agonizing pain, watching their family member be in pain. So it's more of us going to them and introducing the idea of opioids and then coming to us anymore asking.
And sometimes the tension is, even with pharmacies needing overrides, insurance companies and other pieces, when it's like, this is for cancer pain, and yet needing to go back over and over again. And so languaging, when you're talking about, this is not narcotic use, you are not a narcotic user, this is for your pain and relief to improve quality of life. So I think the way that, the additional extra steps, there can be a lot of antagonism sometimes in trying to get authorizations that lead delays. And so if a patient is not able to fill that script and there's 3, 4, 5 days, or they're not telling that to their provider, that pain is becoming untreated. And then we have an escalating period of time and perhaps an unnecessary hospitalization or a pain crisis that could have been avoided.
And that piece about many formularies have exceptions around whether or not you need to get a prior approval to have an opiate for your given symptom that a patient has. And most formularies have, by the insurers, have overrides for some opiates where you could get them the day you write the prescription. But then some pharmacies don't actually know that that's true. We had one day where our social worker spent an hour or two with the Medicaid pharmacist to help explain to a commercial pharmacist how to enter in their computer the number where to indicate this is for cancer pain, so that it would go through. Where providers having to be on the phone for things that are approved, and the pharmacy doesn't know that there's exceptions for patients with cancer. Or then what if you want to use a drug that's not on the formulary, and what's the effort of getting that drug in a timely fashion for someone with cancer? I mean, show of hands for people that are in any part of that step of trying to get access to opiates, if they've had barriers in getting timely access through pharmacies related to insurance or the pharmacy. So that's where we can't step back and not say, this is important, and we also, while we curb the opiate epidemic, we also need to make sure we're taking good steps to make sure there's good access for opiates for patients with cancer. Anything we haven't kind of talked about? There'll be more time with the table discussions, but.
Well, there's also the barrier of the pharmacy may not have the quantity to dispense your prescription. So you need to go to multiple pharmacies to find. So sometimes a pharmacy may not have stock on hand. So there's questions for some of the medication depending on where you live, and access in rural communities or our bush communities is even more difficult. So access continues to be, just having the full dose to fill the script is an absolute concern week in, week out.
And what happens if a pharmacy says, I don't feel safe because we might be targeted to have opiates stolen because of addiction disorder, but what are we doing then to have access to opiates for people that need it for their cancer pain? Or end of life, and that's a whole other thing. We'll stay for the Cancer Policy Forum on that, issue. So the barriers to the access, and then the patients and the families and their perceptions and what that feels like to them when they're taking these drugs, or maybe won't take them because of that stigma. So actually I'll just highlight that there is an opiate risk tool. There's evidence around the risks of developing a substance abuse disorder in using opiates that's taught to be used by providers to help assess when you're working with someone and prescribing opiates. It's not to say that we're not careful about making sure people don't develop addictive disorders related to our cancer pain management. And sometimes patients have active substance abuse disorders and have cancer pain and need opiates. And so it takes a lot of attention and an inter or multidisciplinary team to help people. But there's ways of identifying patients at risk. There are steps to help minimize the risk of that opiate getting out of control. And there are ways to use opiates and get people access to substance abuse programs. I'm not going to go through this except to say the National Comprehensive Cancer Center has a great guideline on how to titrate opiates. And if you're a primary care provider and you have someone with cancer and you're thinking they have uncontrolled cancer pain and I don't know what else to do next, Of course, there is curbside calls and there's referring your patients, but there also is support in how to change the dose and go up in increments so that you're safe. One thing has become of this opiate epidemic is sometimes providers are uncertain what an overdose even is, that they're not willing to even go up 50% on an opiate for someone with uncontrolled pain, which would be a very safe increment to increase. And so all providers need to know how to prescribe opiates safely and how to adjust them, and to understand at what point puts someone at risk for an overdose. Tripling a dose would be an unusual and unnecessary step in someone with uncontrolled pain and could put somebody at risk of being sedated or even in an overdose state. I would never have someone who took one Percocet who says, I'm not comfortable, say, well, next time take 3. And this gives some guidance around that. Increments of a half to doubling a dose in a dose that was previously tolerated is not going to cause an overdose. But providers need to feel responsible that they have to know. They can't just say, I'm worried that you might overdose. They should be have access to information if they don't already know, or call curbside or refer to make sure that their patients can have their doses adjusted if they have uncontrolled pain. So my summary is opiates are important for cancer-related pain, and addictive disorder is rare, but it's important to watch for as well. And provider familiarity with dosing guidelines is an absolute requirement for us to take good care of our patients. Thank you.
Thank you. I'm going to ask thank you, Dr. McVeigh, Dr. Tom Grissom, to join us up here. The most important thing about Dr. Grissom's background, of course, is that he's a Husky. Kinda.
Went to med school.
Went to med school at University of Washington and has been in the field of pain management for pushing 20 years now. And a couple other things I just wanted to highlight. A member of the American Academy of Pain Medicine and the American Society of Anesthesiology, certified in anesthesiology and pain management by the American Board of Anesthesiology. And I'm going to say, without further ado, turn it over to you, but give me just a second to pull your slides up.
In there somewhere.
It's the one that says Tom. We try to make it easy. So,
So how do I turn it to the next slide?
So there's,
Okay. Then you can go back.
this one, yeah, back and
That's
forth.
good. So, real quick, my background, I did family practice first, then I did an anesthesia residency and a pain fellowship. My pain fellowship actually was cancer pain for the most part, for about 2/3 of that. Came up here about 8 years ago. And so, in this forum, my intention is to do a couple of things. One is to kind of tell you what pain doctors are and what we aren't. And the second thing is try to start to bridge some ways in which maybe we can start to create better referral patterns for what we do and what we don't do. First thing, everybody kind of, what is a pain doc? That didn't work. I apologize if I sound like I'm slurring my words. It's not going in there. Okay. Okay, I knew I could push a button. I had oral surgery on my mouth yesterday in Seattle, so I'm actually on Percocet right now. So if I slur my words, that's why. So is it working now?
Yeah, that's right.
So what is a pain physician? So I'm going to tell you a couple of quick things. I get access to be able to see through the drug reps who are the biggest prescribers of opioids in the state of Alaska. Okay, we have the biggest pain practice in the state of Alaska. I'm the busiest doc in that practice. I'm not in the top 20 in the state.
Wow.
Okay, and so I'm trying to put that in perspective. A lot of the people that appear on those lists are primary care docs, internists, family practice doc, GPs, and I'm not putting anybody down, but what I'm going to kind of allude to is there's a perception that pain docs are pill pushers, that we overprescribe, And some of that's justified because we get lumped into the same category as some of the people that aren't really well trained and are doing this kind of stuff. So I throw in with people who provide narcotics, the oncologists, which usually do a pretty good job too because they have a lot of experience doing it. Palliative care, which is kind of a new field over the last 10, 15 years. Training programs, I did an ACGME accredited fellowship, which means that it's board certified, it's monitored, it has expectations, it has guidelines. And most of the people in this state that are prescribing opioids have never had any real training. So their training is what they read or what they go to a course or what they, some of the drug reps come by and tell them how to prescribe these opioids, etc. And I found historically that that's not the best way to do that. I can tell you in my practice, probably in the last 8 years I've been in this state, I've probably personally only started patients 10 times on opioids. They all come on opioids. Sometimes it's some ridiculous doses, and I'll get to a couple of those. The certified training programs, the American Board of Anesthesia has fellowship programs. They are letting neurologists, physiatrists, and anesthesiologists into those programs. There's the American Academy of Pain Medicine, which has a pretty rigorous certification process. And there's 5 specialties allowed into that. Spine guys, both neuro and ortho, psych, anesthesia, physiatry. Is that 5? I think so. And then basically, there are workshops, there are training centers. There are cadaver workshops if you want to get into learning interventional techniques. And so that's really all the training there is in this, coming to these kinds of courses. So everybody, you guys have done a great job explaining all the different kinds of pain. And so I just kind of threw that list up there. When you were talking, I guess from a clinical perspective, I really think there's 2 good ways of defining pain for most clinicians. It's acute or chronic. And we all know that acute pain can become chronic. Okay? And that there's neuropathic and basically nociceptive pain. Opioids are great for nociceptive pain. Broken legs, twisted ankles, oral surgery, etc. Historically, they're not as effective for neuropathic pain. They can be if they're delivered in different ways, via intrathecal delivery systems, for instance. You can get doses high enough to actually have an impact without the side effect profile. But historically, that is the case. Do opioids work? Well, I think you guys already got that answered. Alternatives, I want to talk a little bit about that. So, and especially as it relates to cancer pain, because a lot of this is basically Cancer Society meeting. So, there are an enormous number of cancer-related pain syndromes, if you want to call that respond to alternative therapies, whether that's sympathetic blocks, whether that's interventional techniques like STEMs, whether that is prophylactic vertebroplasties, and I'll explain what that is in a little bit. We do neuroablative procedures. I inject phenol and alcohol in the spinal column to kill parts of the spinal cord when it's appropriate. There are not a lot of people who do those kinds of things, and unfortunately, there's not a very good mechanism to get referring physicians to refer these patients in a timely fashion when you can improve their quality of life. A lot of times we get them kind of in the palliative care end of life stage, and all we're doing is essentially trying to make them comfortable and may not improve their quality of life a whole lot. So, the problem, as I alluded to earlier, is lack of education, and that's difficult. I don't think there's a real easy way to get around lack of education. I think the way you have to do it is almost legislate or somehow create triggers in society or in medicine that allow us to try to artificially fix that problem. For example, if somebody is on a significant dose of opioids, and I will give you an example. I had a patient who was sent to me, he was on basically 1,800 methadone pills a month. 10 milligrams of Valium 4 times a day, Soma 350 milligrams 4 times a day, and they were taking temazepam at night as well. Okay, that's a patient who somewhere before that point should have probably been referred to us. That patient now is basically off Soma, off Valium, off temazepam, and down to about 360 pills of methadone, which is still a substantial dose, in hopes of weaning them down. So we see these patients when they're very difficult to deal with. And that's not even a cancer patient, that's not even the highest dose I've seen. But let's talk about some things that would, I think, trigger and make patients' quality of life much better. And I'm not advocating my practice, I'm advocating anybody's practice. Shingles, anybody at the age of 50 should be sent to a pain clinic on day 1. Anything short of that, I actually consider malpractice. because sympathetic blocks on patients in the first 2 weeks after the age of 50 will lessen the likelihood of developing postoperative neuralgia to 0. Literally, 0. After 2 weeks to 2 months, about 10%. Beyond that, you get an 80-year-old person, they have potentially a 70 to 80% chance of developing postoperative neuralgia, which is worse than the shingles, and is one of the biggest reasons for, let's say, suicide in the elderly. And that's somebody that basically we could have prevented from ever happening. State of Alaska, you know how many compression fractures we get in patients who are elderly, cancer, tumor involvement in the spine? It's quite high nationally if you look at the statistics. Last year, there were only 20 vertebral augmentation procedures done in the state of Alaska. And we used to do, in Idaho where I was at, and we had a catchment area of about 200,000 people. We did 5 a week. So what are these patients doing? Well, I see them after they've got chronic pain associated with their compression fractures down the road, and historically, they're on high doses of narcotics, and you can't fix them at that point. So that's another thing that we can fix almost immediately. Those patients come in an ambulance, they go home in their own car. That's essentially how effective that is. Patients who have chemotherapy-induced neuropathies. You know, there's some great solutions to that. The drugs that everybody uses in primary care are basically Neurontin and Lyrica, but there's some better anticonvulsants. Lamictal is a much better drug. Spinal cord stim works well for those and get patients off narcotics completely in that scenario. Intrathecal pumps, we get to use those for visceral tumors. And so when somebody's got, let's say, pancreatic cancer or let's say chronic pancreatitis, you can put an intrathecal pump in and run just straight local anesthetic in it, even without a narcotic, and segmentally block part of the spinal cord and essentially take the narcotic use away from these patients. And those are problem players. So, bone involvement in the spine. You know, somebody's got a big bony tumor that's sitting at T6 or T7, and that patient is going to go off for radiation therapy. Well, if it's a big enough tumor, they're probably going to collapse and have a compression fracture. We've worked with the radiation oncologists out in the valley. Sometimes we get these guys to finally do it. We'll send patients to us, and we'll basically debulk the tumor during either a kyphoplasty or a vertebroplasty or spinoplasty. Then send them back for the chemotherapy. They get radiation therapy, and they get radiation. They debulk the tumor. We've debulked it. They're better off, but now they're stable. They're not at risk of having a compression fracture. And the risk of death or mortality with a compression fracture is 5% per level. So that has a big impact on patients. I can't even see this here. It's part of the perk set. So I guess from my perspective is in sitting down and trying to legislate things and trying to come up with some kind of a mechanism to improve quality care, patient outcomes, and get these patients referred to appropriate resources, is to somehow legislate or put into place triggers that provide an opportunity for these patients to at least be seen. I came from a very good cancer pain program in Syracuse, New York, where I did my fellowship. Any patient in that system that was put on long-acting opioids, extended release opioids or methadone, immediately triggered a referral. It didn't mean that we were going to do anything, but they were in the system. We could identify somebody who might have a problem. Somebody who had pancreatic cancer that we could, early on in the onset of that disease, do a celiac plexus block, a neurolytic celiac plexus block, to prevent them from having some pain for a period of time that may come back, but at least we've improved their quality of life for maybe 6 to 9 months, and it can be repeated a couple of times. People are on high dose of opioids. Somebody's on more than 100 milliequivalents of morphine in a 24-hour period of time. Those are the ones that are simple, that I can, and along with postoperative neuralgia prevention, compression fractures, those are real simple triggers. There are a whole bunch of other ones that we could sit and talk about, but I think we need to not only talk about appropriate use of these meds, but also appropriate use of things that we can do to prevent escalation of those meds or overuse of those meds down the road. So I just kind of wanted to talk a little bit about what you guys have. What's your perception of pain docs? I was probably pretty close.
Pill mill. That's a pill mill.
Yeah.
I didn't catch your last name, Dr.
Grissom.
Dr. Grissom. Thank you for that. It was excellent. And there is an excellent one, probably somebody practiced with out in Eagle River who spoke at ANTHC, I think 2 years ago on this. And also very enlightening. I'm really curious about the triggers to refer. You mentioned consider legislation. Do you think it's possible to put something like that in statute? I mean, and what kind of consensus would the medical community have to come, to agreement on to actually, get something to kind of put sideboards up on trying to legislate something like that?
Well, I don't want to prevent somebody who's gone off and done adequate training, let's say a family practice doc who's spent a lot of time going off and doing coursework and feels very comfortable and does a good job writing meds. So there needs to be some way of setting up some legislation that provides somebody an alternative way if you're not, I mean, from my standpoint, if you're ACG and you're accredited pain fellowship, you satisfy whatever requirements they are. If you've gone through the American Board of Pain Medicine and you're practicing, those might be triggers that says, okay, you're adequately trained to do this. The next question then becomes, how do you get around that? And I think you can have training programs or educational programs that would meet the criteria to be considered outside of these triggers. So, give you an example. If I'm a family practice doc and I feel very comfortable writing somebody who's on 100 milligrams of extended release morphine 3 times a day and a breakthrough pain med and they're doing great, I don't want to have to jump through a hoop if I feel that if I'm comfortable with that and I've been adequately trained. So I need to somehow come up with a structure that allows people to gain some kind of certification that allows them to be deemed pain qualified. Okay? But the ones who aren't, I think, need some structure. They need a trigger. I mean, I cannot tell you how many times I have seen patients, there's another one. I had a patient who came in at 80 milligrams of OxyContin, 5 pills 4 times a day. And 30 milligram oxycodone for breakthrough pain was taken 15 a day. And Valium and Sona and Ambien. And so the question becomes, that's a disaster. And that's a very awake patient who's got on that dose over a long period of time. But now how do I deal with them? I have to now gain that patient's trust because they think if they come off those meds, they're going to be miserable. I spent 3 months trying to get that patient to trust me. And now that patient's on 80 milligrams of OxyContin 3 times a day and is on off their Valium and we're weaning down their short-acting meds. We've got them cut in half now. And we're talking about doing a stimulator because the guy's had 4 back surgeries. And so there's we should have never gotten to that point, is what I'm saying. And so we need to come up with some kind of guidelines that prevent that kind of patient from falling through the cracks and suddenly being essentially in a pill mill. And there are docs. Go ahead.
Are there extra fees attached when Medicare patients want to see a pain doctor
No.
versus their regular provider?
No, there might be some requirements that get a referral. So, I mean, the self-referral world has kind of gone away. And so a lot of times the VA, for instance, if we get a VA patient, they have to get, if they haven't been seeing 6 months, they need a referral, which kind of seems crazy, but all those things are designed to, to try to prevent access. I hate saying it, but it's the truth. Yes?
Doctor, I totally understand what you're saying. As one of the two clinicians in the state legislature, could I suggest that that's what the regulatory process is for? In other words, instead of asking the state Senate or state House, the legislature, who are citizens, fishermen, insurance salesmen, etc., to write a law like this, I suggest you approach the Board of Medicine, which are clinicians who know this subject and will write something reasonable.
I hope.
Well, I can guarantee...
So you're a clinician, and it's like herding cats.
I understand, but I guarantee you, put this in the legislature and it will go down it will be a very bad outcome.
I was just going to say, but my concern is sometimes the access to specialists in our state is a big issue, especially in the Alaska tribal health system.
Sure.
And I would say primary care, even access to a family practice doc is a challenge in Bush, Alaska. And so we can't think in a kind of metropolitan or big city fashion for our state. We need to be really cautious that who we're talking to are community health aides. We're talking about nurse practitioners and physician assistants who are serving in some of the most underserved areas in this country. And I think if we wave a wand to pass legislation that restricts it too much, I worry about those underserved rural populations. And I completely agree. We need to establish best practices. We need to have standards that we all agree to, like certain standards. But the thing is, it's about not routing everyone to a specialist, but it's about sharing those best practices. I know Ursula mentioned curbsiding, having ways where primary care docs, as well as nurse practitioners and community health aides, have access to getting the support they need while they work in these really rural, remote communities. Because that's the reality of Alaska. So we have to be really careful that we are balanced in the decisions that we make.
That's a good point. And one of the things that we've done in our practice is we've initiated a telemedicine program in hopes that we can put telemedicine portals in those outlets and allow them to curbside consult us via the internet, if you want to call it that. It gives them an opportunity. They wouldn't have to see patients. We could follow patients up that way as well. But it allows us an opportunity to say, hey, this is somebody you really ought to refer, or this is somebody that you really ought to be careful of. And that is a very applicable solution to that problem in this state, at least when it comes to opioid utilization and pain medicine, if that's what you want to call it. And it's a good point. There's not an easy fix to this whole thing. Look, the legislation they put through to control opioids to some degree in the state already, I salute them for having attempted, but it created a backlash. I'll give you a perfect example in my practice. We may have 6 providers in the same building at one time with 12 MAs. And now the state's put, my MA is not allowed to look up on the PDMP their opioid history and then present it to me. I have to physically myself go do it. So somebody in the pharmacy world decided that one access for the whole clinic wasn't enough. Every provider had to have their own. I don't know what that is other than somebody spying on me to see if I'm doing my job. Okay? It creates a backlog in a busy practice that doesn't benefit anybody. So there's some things that need to be changed from that standpoint. But I salute the idea. Having a drug monitoring program, that should be a national thing. ACIP has been trying to do that for 10 years. And for some reason, they can't get the federal government to do it. And it's a simple thing. I practice in Idaho near the border with Oregon, Washington, and Idaho. Washington didn't have a screening program at one time. Idaho had a great one. Neither did Oregon. So all the patients had to do was go get their scripts filled in another state. And they just, circumvented what we were trying to do. And that's just practice good medicine. So, yes.
What you just outlined was not the intent of that legislation.
I know that.
And so thank you for informing me and 2 House members here of that, because that, again, is at the regulatory level. That's obviously something I missed in looking at that regulatory package. But I will do what I can to get that corrected. Your individual medical assistant should be able to look up your patients.
Well, they should at least be able to look it up, print it off, bring it to me so that I can
Yes.
review it when I walk and see the patient.
That is the intent.
And then we can shred it.
That is the intent.
But I was told by somebody in the pharmacy side of the world in the state of Alaska that somehow they thought it was a HIPAA violation that if an MA in the practice, who gets to see all the patients anyway, saw somebody that they weren't supposed to see that day, and I'm like, you've got to be kidding me.
Understood.
You've been in
It
a
was not the
practice.
intent of the legislation.
I know that.
That gets messed up sometimes, but thanks for letting us
Cut me
know.
off, I'm sorry.
I'm going to cut in.
Oh.
I'm going to cut in because this is exactly where we're going, and we're going to have another opportunity to talk as a group again in a little bit. But what I'd like to do now is hand this so I don't talk into 2 mics. What I'd like to do now is transition into the table discussions and see if we can get some more of these concrete ideas about, I think all these presentations have really laid out, and the conversation in the room has really laid out that we do have challenges and opportunities. And this is where I have to stand up and sing the Alaska flag song or something, because we live in an amazing, amazing state. The people that are making decisions about this issue in our state, many of them are right here in this room. and those that are not, we can pick up the phone and call. We have such opportunity to be a leader in helping figure some of these things out in our state. So with that, the next activity is the table discussions, and there are several topics. There's 4 different potential topics that you can discuss at your table. There are folks who have a star on their name tag, if the name tag hasn't fallen off, who are going to be helping us walk through these questions. What I want to make sure is that there's somebody willing to sort of walk through the questions and take notes. You can deal with things that are not on the page. Just pick one of the topics among the folks at your table. And I would say make sure there is at least 3 or 4 people at every table so that we can have a good conversation. Okay. And we're going to have about 20 minutes to have conversations on this. And right now, I'm not going to be able to hear out of here.
Emily, in retrospect, the bill might not have been a good idea.
Live and learn, huh? Yes. Live and learn. Thank you all for the lively discussion. Now, what I would like to do is switch us back into some of the sharing around the tables. What I do not need is a full report out. That's why somebody was taking notes, which is awesome. Thank you, note takers. What I would like to, though, is to go around, and if there is one highlight or one question that came up, I would love to share that with the group. We have all of our panelists. Let's see, I've got Dr. Grissom and Dr. McVeigh, Dr. Butler, Pat,
What's her name?
is here. Good old what's her name? Pat really, is here. And so actually, could I ask the panelists to come back up front because it's going to be a lot easier to deal with the microphone that's here. And Julie's my. Yep, okay. Perfect, thank you guys. Okay, so from the tables, Dr. Carmelli, do you have something that you think what was the most interesting thing that popped out at you, or a burning question that you have?
I was just going to say we tackled like the system issues, and we just it was just, I think what was interesting is thinking from a patient perspective that our healthcare system has so many silos, and being able to break down those silos. So there's so much that's needed for patient education, provider education, and then also helping our patients to be able to navigate the system to get the appropriate care that they need. And I think helping our system to grow to support that navigation, especially when you're having pain, and getting access to that interdisciplinary team approach that's so needed.
Thanks. I'm going to go over here. Oh, she's got it. Okay. I told you she was
So our table discussed the issues with diversion, so secure locations and partnering with community organizations such as banks to store potentially and house medications and utilize secure locations in communities that are existing to provide easier access for local pharmacies to get to the medications. And then also we discussed the delay in the PDMP data, so refreshing that faster so physicians aren't concerned with accessing that data that might be old from the previous week. And then also potentially exploring third-party managing of that PDMP data.
interesting things.
Yeah, I mean, we talked about PDMP a lot at our table as well.
And just to highlight, I guess the main thing with the interface is poor. That's the feedback that we got. I mean, having to input zeros for birthdays, the first name, last name situation, and having to click, 6, 7 times to get to what you need. So just an overhaul of the actual interface. And then we also talked about how Alaska, a lot of times, sometimes will want to reinvent the wheel rather than going with things that have worked in other states, and instead maybe rather trying to use regulatory or use a legislative arm that we could petition national professional associations for standards and best practices.
Thank you. Abby, any highlights or questions? I have one question.
Yeah.
But you did highlight it.
Yeah. We also talked about PDMP quite a bit, and there was actually a law piece that if you wanted to share what you found and just to address it because it came up in the conversation.
Sure. What's come up is the fact that clinicians cannot ask their medical assistants to check the PDMP for them and get the data, that the clinician has to do it themselves. That actually we corrected in the most recent bill, but the first bill, the Medicaid reform bill, said it had to be a licensed person. So what I've been talking with some other folks about is actually licensing medical assistants, certifying medical assistants, and that might be the easiest way to fix the bill. Apparently that was some advice from Dr. Butler, and as it turns out, I have a Board of Medicine bill that they've requested, and I can easily insert that, so we're working on that.
And then just real quick, and beyond that, we talked a lot about, we've looked at the systematic issues, and really our last discussion was talking about more experts speaking at the various boards, so medical boards, especially the medical boards that are prescribing capabilities. Just more provider education through utilizing those boards, kind of going to the people and to the conferences that these boards have annually. So that was about it. Yeah, thanks.
Great. And who was Amberly.
Our star.
Amberly. Left you all. Does somebody want to share a highlight that you all had, or something that was interesting that you know, a question?
Yeah, she's the one who's.
I did the most talking.
So what topic did you guys discuss, Penny?
Patient and caregiver education. What we kind of highlighted the most was the need for better care coordination, for more education and training, not only at the physicians and nurses levels, but also coming down the line for the general public themselves, our primary care doctors. And that was pretty much what we felt, I think, was probably the most important thing, was finding some way to come up with the care coordination. I know we've tried navigators, we have social workers and other groups, but needing someone who can kind of be a lead. In outside areas, there are teams. You go to MD Anderson or Sloan Kettering or someplace like that, and you walk in and there's a whole panel that's ready to work with you. We don't have that as such here in Anchorage. So I think educating through a navigator or some type of thing and bring it down to the levels. We also discussed support groups and the importance that people learn about care, but I think it has to be at a higher level.
Thank you. Dr. Grissom, thank you for stepping in. Highlights?
We also did patient and caregiver education and highlighted similarly this idea of the most productive education being an ongoing relationship with the caregiving team, and a couple examples of that in our little group here were at nurses providing medication education at NOC Oncology and multidisciplinary rounds at PAC, and finding ways to kind of extend that into busy outpatient office is sort of the goal.
Thank you, ambitious goals here. Julia,
So one of the things Emily asked us to do was have a question, so I'm going to throw a question. How do we, with the media that's being shared that has a message that opioids are bad, how do we insert the message that, but they're good for cancer pain? That's one of the questions we wrestled with, and does anybody want to address that?
jumping right to the heart of the matter.
Yeah, that's a great question, because I think that is the concern, because the media tends to be very black and white. So trying to deliver a nuanced message can be very challenging, and I find that sometimes even when speaking with providers, that can be a challenge. So I think the way you just said it is kind of good, although I would start with actually opioids are good and powerful medications, but like many things that are good and powerful, if they are not used carefully and judiciously, they can lead to big problems. So I'm not a communications expert. I have a hard time finishing a sentence, but just in terms of kind of a philosophy that I think all of us can potentially use in communicating with patients or when we have an interaction with the media, it's probably better to start with the positive and then talk about the negatives, because right now the focus is primarily on the negatives.
Thank you.
I'd add to that, back in the mid-90s, early 90s, there was a push nationally to get physicians to prescribe opioids more liberally, and the pendulum went one direction and went too far one direction. And now we're seeing the pendulum go back the other way. And unfortunately, cancer pain got thrown into the whole bus trip going the other direction. I hope, I think you're right. I think you need to define opioids are not evil drugs. They actually serve a purpose, not just cancer pain, but otherwise as well, but they have to be used judiciously. Unfortunately, that's not what you're seeing in the media, and I don't have an answer because the media's got a narrative they're following now, and I'm not sure you can get off of it. I just don't want to see the pendulum go so far that it was back in the early 90s.
I think one of our group of student nurses here with a great discussion suggested what had already been talked about, namely it's an addiction epidemic, and we need to remind people when for us not to go out of here talking about the opioid epidemic, but maybe the addiction epidemic. And the other was we talked a lot about rural medicine and telehealth and how much, we hope it will have a big impact and provide a lot of opportunities around Alaska, outside of Anchorage and some of the cities here.
Thank you. Hold that thought about rural medicine and telehealth, because I heard some really good, important questions come up. And I want to go back and address that in just a moment. But first, I want to hear.
So we discovered we are at a table where we are all or have been patients. And my particular affliction is hearing loss. And so I did not hear Emily say we should pick a topic. We tried to do all 4 pages. Notwithstanding, we came up with some marvelous feedback. One of the things on page 2 would be that how do we promote education around palliative care? It should really be integrated as an aspect of all clinical coursework. Not just a standalone or not just part of pain management, but whatever it is, if it's OB/GYN or if it's pediatrics or end of life, how you deal with the pain part should be there. It should also be present for all clinical levels, from a PCA or maybe even a mother, all the way to the specialist. One of the things that we got to on patient barriers, one of the real challenges is just proving you have pain if you're a patient, because it's invisible. And we tried to think back to the, you know, the history of this. Opioids is something, but what about fibromyalgia? What about mental illness? You know, this has just historically been such an issue to be able to describe something that's very, very personal. Marie let us know that there is cost assistance, payment assistance for all types of medicine, even for very, very expensive cancer treatment drugs, for infusions and so on, that she can get paid for, except there is no payment assistance for pain medicine. Wow. I'm sure there must have been a tremendous amount of other great information, but that's it.
Awesome, thank you. I'd like to take it back to a question on that role. Did Dr. Carmelli step out?
Yeah, he had the lead.
He had the lead, okay. Are there other folks, maybe Serena from the NTHC's program? A question came up about access to pain medication in rural Alaska, and some of you may have an answer for this as well. About physically what happens when somebody's prescription runs out and they're in a village and they don't have a local pharmacy. Just you're not going down to Fred Meyer to get it filled again. Does somebody want to?
Well, I used to work in that.
Oh, thank you. Perfect.
So I worked out in Kotzebue for 6 years and Bethel for 7. And if you're in one of the regional hubs like Bethel or Kotzebue, they have a big pharmacy and pharmacists available. But if you're out in Buckland or Deering or Marshall, one of the distant villages, you need to have enough medications there. And that gets to be a real problem because the health aides need to broker that, stuff gets stolen out of the clinic, it can't be secured, it's very hard to keep track of it. And then if you do run out, planes aren't flying because the weather's poor, you can in withdrawal. And I remember a particular patient from Deering that I think was opioid addicted, not just dependent. And the physicians in town were as responsible as anybody, but this lady would run out on Saturday night when I was working the night shift in the ER there, and I'd have to give her some T3s to get through the weekend because you don't want her withdrawing out in the village. And so it's a serious problem. And if you've got a patient with cancer who's decided they would prefer to die in their village, making sure that they have adequate pain medications to deal with that is very, very
Thank you. This is where when we all talk to people from outside, we have to say, Alaska really is different. Are there other final comments that any of the panelists want to add to this discussion?
I'm glad you asked. I wanted to just let people know that the Palliative Care Alaska Network, which is an all-voluntary group, is sponsoring their first Palliative Care, the New Face of Hope conference. It's October 14th. It's free. You should register. We are providing breakfast and lunch. And Dr. McVeigh is speaking. Bianca is speaking. It is really mind, body, and spirit. So, but we will be talking about opioids, and if you're interested, great opportunity. There's a bunch of these out on the table out there.
Any comments?
Okay, actually, I'd just walk in and ask a question to the group. But in some of the market analysis of what are some of the educational gaps for the public, and what are some of the motivating factors for certain behaviors, one of the things that emerged that I can really identify with, because this is exactly what I do, is that people are very hesitant to get rid of leftover medications because you just might need them. Yeah. So I just had my 4th grandkid, and my wife went around and put all those electrical outlet covers on, and thinking, is that to keep the electricity from leaking out? What's that? But, you know, we child-proof our homes, but we oftentimes don't child-proof or adult-proof our medicine cabinets by going through and getting rid of what's left over. And what we heard from people doing a kind of semi-quantitative analysis was, well, I want to be able to share it with someone if I need it. And that's been, you know, we thought, well, that's pretty easy in terms of our message is when it comes to opioids, not sharing is caring. And some of the anecdotes we've heard that have concerned me and led to some conversations with the FDA is that some of the ultra-high dose single unit preparations may be much more dangerous than we've previously recognized, like the 80 milligram Oxycontin. You know, that in that single pill exceeds the 90 morphine milligram equivalent, which is kind of the level of concern that's been thrown around quite a bit. And so my question for the group here, because I've talked to some of you individually, but wow, you're all here together, is if the FDA were to withdraw that, or ultimately what they would do is they would withdraw their approval and then Purdue would withdraw it from the market. Do you think that would cause major problems in palliative care or management of cancer pain? And I see at least one person nodding yes. Could we maybe hear a little more? Because, you know, I hear some people say, well, you take more pills. Well, if there's a problem with pills, you could go with liquids or fentanyl patches or whatever. So tell me more.
Was that you, Serena?
Yeah, that was me.
Okay.
So a major issue is the ability of people, especially in situations where they end up taking large amounts of pain pills, they don't always have the ability to take in very many pills. And yet we're throwing all these bundles of pills at them. Their stomachs, their throats don't deal with it very well always. Their stomachs don't deal with it very well always. And there are only so many pain medications that are currently available in patch form. There are only so many medications that are commonly available in liquid form. We would really need to think ahead if we were going to take some of the more packageable sizes of long-acting medication off the market to make sure that the market had enough supply of feasible alternatives with enough variety that you could rotate someone to a different agent if one agent wasn't working for them, because that's something that we reasonably frequently have to do.
Thank you.
Ursula, did you have a comment?
No, I agree with that. I think also the quantity limits would have to be adjusted for one of the
barriers to getting opiates for cancer-related pain are also how many pills you're writing for. And there's a certain amount that in the Medicaid formulary and sometimes other private insurance formularies sort of cap how many you can prescribe without having to do paperwork and send your documentation, which can sometimes delay access by a number of days. That would be one concern. Are you specifically speaking of just one drug that's a long-acting, high dose?
That's probably top of the list, and where there's sort of a lineup of parents who are saying, I lost my kid to this. So trying to balance the risks and benefits, which ultimately FDA can do that. That's their job, but I just don't know how much to push on.
I don't know if you can say to investigate the story. I mean, was it someone taking one pill and not realizing it was so strong?
Yeah.
Or was it somebody looking to purposefully taking a high dose?
There's stories of both.
Real quick on that, I mean, the first formulation of OxyContin had a biphasic release, and because of that, people got a real rush on it, and a lot of people liked it. The new formulation doesn't have that. But having said that, all these narcotics or opioids are all equally abusable. And we're picking on OxyContin because they had a great marketing plan, and they are the most readily available and they're abused the most. But it's infinitely easier to get fentanyl out of a patch. And to tell you how easy it is to find this stuff up, go Google it. Okay, there are websites that are dedicated to tell people how to get your sustained release opioid out of whatever preparation it is, regardless. So we can make smarter pills, and we just make smarter rats. They just figure out ways to abuse these things. So, you know, you can pick on OxyContin, but you know, fentanyl 100 mic patches are lethal. You know, it's 70,200 micrograms of fentanyl in that patch. You know, and anesthetic, that is an induction for a heart. So I can get all that out of there in about 2 hours. So the point is, you know, I kind of agree with that. You can't legislate personal responsibility. That's part of the problem in this whole thing.
I might add, it's interesting bringing up fentanyl because that's been implicated in, I think there's been 1 or 2 celebrity deaths in the last 2 years. And it also is the story of using higher doses than prescribed for the purpose of addiction, probably the extraction of fentanyl or someone who had access to IV fentanyl. It'd be very hard to overdose on a fentanyl patch.
No.
But it makes people hear fentanyl and say, oh, didn't that, you know, didn't so-and-so die from that? But it is the story of, it's really a story of addiction.
And illicit fentanyl is really, I think, one of the biggest challenges.
Yes. We discussed at our table about being more proactive instead of reactive with pain treatment, and this is probably more to you, Dr. Grissom, because it sounds like that's something you can probably do with some of the stem cell and other work. So how can we, and what would you say would be the best plan of action in implementing that in cancer care, where we can remove the silos that someone described and really start having the conversation go to be proactive on that pain treatment versus reactive?
Both those. Short of education between physician education or clinic education, there's not a really good answer for that. I mean, there's a reluctance. I mean, got this water caught in my mouth, I apologize. But there's a reluctance sometimes for physicians to have time to sit down and talk to other physicians about what they even offer. I mean, I run a busy practice, and so it's hard sometimes to take 10 minutes out of a day to go talk to somebody. It's hard to get docs to go to a conference and actually show up to the lecture. I mean, we all see that, and we've got a limited amount of time. So, you know, I know from our perspective, we're more than happy to go out and talk and interact with other groups, you know, whether it's oncology groups or orthopedic groups or the people that are involved in this, talking with palliative care teams to say, hey, these are some things we can offer you. These are the times when they're really valuable, you know, and these are the times when I can tell you, you're probably going to have an issue with this, and you might as well get them in sooner rather than later. You know, and a perfect example is somebody who's on high dose of opioids who's going to live a long period of time, who still has a terminal illness. You know, intrathecal pumps are cost beneficial for about 3 months. So somebody's got a longevity of 3 months or longer, and then that solves a lot of these problems of access. They don't control the med, we do. You know, we program the pumps. So, and those patients can actually give themselves patient-controlled doses. Those pumps are sophisticated now, so they can actually bolus themselves with those pumps. You can put local anesthetic in those things. There are ways of doing all that. So I guess I'm not answering your question, I'm kind of jumping around it, but it's the issue of education and getting people access and then the availability to educate people. You gotta have a receptive audience.
In working with patients, one of the barriers in some of the pain procedures are the co-pays related to the cost of if it's done in an office versus a surgical center and the device cost. I mean, it is, sometimes there's a personal cost to that. So I've worked with patients where they had seen and had a procedure with a high, you know, it was maybe even a few $1,000s in a copay for a pain procedure. And then another thing came up where they could really benefit from this intrathecal pump that Dr. Grissom is describing. They were saying, I don't want to go because I'm worried about, you know, the cost. And if they've had something in the past for maybe a different procedure, for a different indication that didn't work well, and then a new procedure might be offered for a new indication that maybe has better evidence. So it's a real difficult thing for someone to navigate with someone to kind of help walk them through it.
And that's where a good relationship with a primary care doctor and oncologists or palliative care doctors, and that those doctors have really good relationships with the pain centers to understand what is the evidence for the procedures, and what's the Hail Mary pass, and what's the cost to the patient, so I can help counsel them on how do they weigh these options.
No, I agree. I can tell you our practice is, I don't know if we're unique, but if it's cancer pain related, I can guarantee you that if there's co-pays, you know, if the federal government's in here, you guys are listening to me, go ahead. We'll write them off, you know. You get in trouble if you do that on a regular basis. And, you know, there are times when I think you show compassion and there are times that you can't. But that's one of these areas where I think even the federal government from a Medicaid and Medicare standpoint would have a hard time trying to prosecute a doctor who's writing off that kind of stuff. But that's our practice, you know, and she's right. We can control sometimes the cost, the copay to a patient by doing it in an ASC versus a hospital. It's cheaper. By doing it in an ASC, you might have some ownership in and have some control over writing off a copay cost, because nobody should be denied access because they can't afford it for something that really does improve their quality of life.
Nobody should be denied access for something that could improve their quality of life. And that is the perfect segue. I want to give Barb Fly the microphone for just a moment. Barb oversees advocacy and policy efforts for the entire Northwest states for the American Cancer Society Cancer Action Network, PCSCAN. And she's just got quick comments on some of the things that are going on the federal level as well.
Thank you, Emily. And if I can have you pass those around, that would be great. I'll come over here and try not to move too much so that
Don't do,
Heather
nope.
can get me on the camera. Thanks for giving me some time to address you today. The American Cancer Society is attacking cancer on all fronts. And certainly around the issue of reducing the pain and suffering from cancer, there are many fronts to attack cancer. And one of those fronts is through ACS-CAN and through public policy advocacy. And so on the issue of palliative care, there is a piece of federal legislation that's been before Congress now for a few Congresses, a few sessions of Congress, that's called the Palliative Care, Hospice, Education, and Training Act. So it's got a long name. Those who have been working on this bill for a long time call it PACHITA, but that's what those letters and the acronym stand for. And essentially what this bill does is it identifies and sets up systems to deal with some of the barriers to palliative care. And not just hospice care, but palliative care. Just to I probably don't need to do this for the folks that are in this room, but to illustrate a little bit of it, my mom passed away probably, let's see, like 8 years ago now. And it was before I worked for ACS CAN, before I had much involvement with the Cancer Society. And when she was put into hospice, I was just amazed at the level of support that she got. I got reached out to, my brothers got reached out to, my sister got reached out to see if there was anything they could do to help us in handling the fact that our mom was about to pass. And it was amazing. And then, fast forward a number of years, I started working for ACS CAN and found out about palliative care. I found out that it's not just hospice care. The point of diagnosis of cancer or some other serious illness, having access to a palliative care team can truly improve somebody's quality of life. And it just says, I am more than my cancer. So, what do you want to accomplish? I'm sorry, Ursula. So when you were speaking earlier about pain medication, well, there are lots of considerations. And having the conversation with the patient themselves about what it is they would like to see is a really important component of that. So, but there are a lot of barriers to accessing palliative care. One is just like me, I found out I wasn't alone. People didn't know what palliative care was. So if you're a caregiver or a family member, if you're a cancer patient yourself, you might not even know what palliative care is or to ask for it. Number two, many healthcare providers don't know what it is, or they equate it with hospice care. So there's a barrier to accessing it because of that. And then there's the issue of there not being enough providers trained in the medical specialty of palliative care. And somebody else had mentioned that it should be a part of overall education for folks going into the profession. And so this act would set up a number of mechanisms. Number one is that it would work on workforce development and education and training of the current workforce around palliative care, around that specialty care, what it is and what it's there for. The second is it would do an actual awareness and education campaign so that people actually know about palliative care, know how to ask for it, and are able to, when they need it most, are able to find out how to get it. And then the last way is to invest in research around palliative care. It is a relatively new specialty that has really picked up in the last 10 to 15 years. And there's some initial evidence that shows that palliative care can in fact not just improve somebody's quality of life, but in some cases lower costs dramatically. Think about somebody making less trips to the emergency room because they've got good overall management of their symptoms. And so more research needs to be done. And so as you can imagine, it's not easy to get things through Congress. It can be done. It is not easy. And what it takes are organizations like ACS CAN that know how to take the voices that are in this room, my voice combined with yours, and create the kind of pressure to actually get Congress to act. And we've managed to accomplish a whole lot around moving forward this piece of legislation over the last few years. We are now up to well over 200 co-sponsors on the PACHITA piece of legislation. So members of Congress that have said, both Republican and Democrat, I'm on board, I'm not only supportive of this, I'll put my name on the bill. We've got some work to do in order to continue that push. Representative Young here in Alaska has put his name onto the bill. We're looking at getting our 2 senators to get their names on the bill. So we would like to have your support and your help in doing that, but we would like you to also become a card-carrying member of ACS CAN. And what that means is that you're down for the fight. And being down for the fight essentially means a number of different things. Number one, you recognize that one voice isn't enough. We need to not just have lots of voices, but we need to think about how to effectively combine those voices to bring about change. ACS CAN helps you do just that. We provide education and training. We provide support so that people can actually get to their state capital, get to Washington, D.C. to meet face-to-face with their lawmakers. And you also find out about what's going on. And yes, you will be contacted, and we'll encourage you to do action alerts and emails and call your lawmaker. And you can decide how much you want to get active or not. But the number one step is to become a member of ACS CAN. So the membership forms, I think Emily just passed around. Membership dues are a minimum of $10 for an entire year. We could certainly use more than $10. So if you're able to give a larger contribution, that would be great. And we would just love to add your names to the others here in Alaska to bring about some change both on the state level as well as the federal level. So thank you.
I just want to give another thank you, and I didn't actually introduce Dr. Jay Butler earlier, Chief Medical Officer for the state of Alaska and the current president of the Association of State and Territorial Health Officials.
Very well.
Thank you.
I can't remember it. So.
So Pat, Jay, Tom, Ursula, let's have a big round for our Thanks again to our sponsors, Algone, Providence, Alaska Cybernetics Center, Premier Blue Cross Blue Shield of Alaska, Alaska Native Tribal Health Consortium, Bristol Mothers Group, AARP Alaska, and James Oncology. Woohoo! Now, next steps. The committee is going to continue working. Oh, shout out to the committee. The committee members are on here. Donna Beach, Pat Dooley, Stacy Kelly, Ursula McVeigh, Judith Muller, Eileen Patterson, Sheila Tallman, Julia Thorsness, and Julie Wrigley. Thank you. You organized all the catering for today. Important stuff. Want to thank you for your participation. We're going to be compiling the information that was the notes that were taken and then doing some follow-up with everybody. We should have everybody's contact information. If we don't, please make sure that we get an email address for you before you leave. And thanks so much for being here. Really?